Okay. So I welcome one and all in tonight's lecture. It's going to be endometrial hyperplasia, which happens to be a pre-invasive, pre-cancerous lesion of the uterus, obviously an important part in progressing to endometrial carcinoma. And all my oncology series, I've taken lectures in which in which the pre-invasive lesions were taken first, followed by the frank carcinoma. So we've finished off by now, those of you who have been with me throughout my oncology lectures, and they know this thing that we've dealt with cervical carcinoma. So I took CIN first. Okay, not only that, everything, HPV, PAP screening and stuff like that. So everything, entire pre-invasive lesions were first included, followed by cervical carcinoma, then vulval lesions were included, and then followed by vulval carcinoma. And recently, I did the GCT first, that was germ cell tumor, and then followed by frank ovarian carcinoma. The lecture still is there on my channel. Those of you who missed it can see it. I keep it there for a week for everybody to watch, and then I remove it, and then it's permanently there for all my students who've taken up the regular theory course. For them, it's permanently there till they have their validity. They can watch these lectures as many number of times as they want, and they should. I always say that revisions are very, very important. So if you take up the same material, learn from the same material, watch that lecture again and again, there's nothing that's going to stop you in making it a very, cakewalk through your exams. All right. So all that lecture I'm going to take up later on some other day when I'll be telling you about, how to study. There are also podcasts available, audio podcasts available of my students. Some of them I've taken, live talking to them. Some of them have been kind enough to record their messages and send over. I've put both those audio podcasts on my channel. So these are, those audio podcasts of my successful students who've been through the same journey as you people have been through. Listen to them, take notes, because they are your, seniors who have been through exact same journey. So I'm sure that you will get some real valuable tips and tricks. How did they study? What did they study? How was their planning and management and everything regarding their plan of studies, and how did they fare up in the exams, right till the time of how did they write in the exams. So like I said, tonight the class is going to be a little easy sailing through, because basically I'll be dealing with only endometrial hyperplasia and how it can progress to carcinoma. How do we manage it? Where do we draw the line that no, we have to now, take up a stringent action for this patient, so on and so forth. So let's begin. And one more very important thing, I always tell you the source. These are directly from the GTG, that means Green Dog guidelines. They are very, very important guidelines, as it is also. They're evidence-based medicine. So we are going to we're going to be following those guidelines, which have been already, made up for these important lesions, and we have to follow them. See, talking about the carcinomas is easier for me, because there are always a FIGO update coming up, and that you have to follow. It becomes very easy. But for the pre-invasive lesions, it is a little difficult search, because I have to look for those guidelines which are exclusively made for those lesions which are pre-cancerous. So let's go forward and discuss about endometrial hyperplasia. And we have endometrial hyperplasia according to the 2014 WHO divided into two groups. Again, before I begin the class, let me just ask you once again, if you can see my screen clearly and you can hear my voice clearly, please give me a thumbs up. And that does not mean only one student. I want everybody to participate. I want everybody to give me a thumbs up in the chat box. Tell me if you can see the screen and if you can hear my voice correctly. That will also tell me if you are, ready to converse in the chat, because then in that case, it's very, very important that you are able to tell me if you have any doubt, if there's something else you want me to add in this lecture. That's very, very important for me, guys. It's not a one-way traffic. It does not mean that I'm here, so I'm going to teach whatever I feel like teaching you. No. Everything that you want in these notes, I have to inculcate. Otherwise, there's no point in taking a lecture which is patchy. Patchy information you will get in, many books. I want one lecture which has it all. You don't have to go anywhere else. So now the very important thing is that when I take a lecture based on some guidelines, I do not mix it up with different guidelines. Okay, I tell you the thing only from that guidelines, which is the reason why my lectures are so crystal clear. So that thing we can add towards the end. That this was about GTG, but American guidelines say this, European guidelines say this, and Indian guidelines say this. right? That we can do. But right now, we're going to be talking about one guideline properly that will clear all your doubts. Okay, Shulekha feels my voice is breaking. Somebody is feeling my voice is fine. The problem is a little bit with the network also. I'll just see if my network is with the right. No, it is with the 5G. Okay, I'm pretty safe here. Okay, guys. So try to see your network as well. Go in the little high network zone. Maybe try your. You're there, Rishabh. Are you there in the class? Can you please tell me if my voice is breaking? If you're there, Jitu, you can also tell me if my voice is okay, or you can hear, or it's breaking. So that if 2-3 people say it's breaking, then I'll probably log out and join in again. So if you people are there, can you please just let me know if my voice is breaking? And what about the other students? If you find with my voice, then it's okay. We can carry on further. Okay. All right. You can write in the chat also, Rishabh. That's fine. Thank you so much. Now let's start with the classification. So very, very important. Do you know that, when we were students, we used to study about 4 classifications of endometrial hyperplasia: simple, complex, with and without atypia. So there were 4. But 2014, WHO simplified it. It said that you just call it endometrial hyperplasia with atypia or without atypia. Either it is simple endometrial hyperplasia or it is with atypia. That's all. Do not confuse it any further. So we went ahead and did the same thing. There are some couple of risk factors associated with endometrial hyperplasia. There's some kind of people who are going to have endometrial hyperplasia. Can you quickly tell me what are those people who have a significant risk for developing endometrial hyperplasia? We'll start with a great discussion with my students. So I'm seeing what? Students are there, they're not there. What is the problem? Okay. Decent enough is there. Usually it's just double of what I have right now, but it's okay. Yes, great. So star gets another star from me, and you see you're absolutely right. So PCOS is a risk factor, obesity is a risk factor, nulliparity is a risk factor, going through infertility treatments is a risk factor. What else? Taking HRT is a risk factor. Being on tamoxifen for breast cancer is a risk factor. These are all risk factors for endometrial hyperplasia. And one very important thing, if you have that germ cell tumor, the granulosa cell tumor, that also leads to endometrial hyperplasia. In fact, it's a very, very important term to be coined here. But we are talking about usually the perimenopausal age group, where GCTs are not very, very common. Okay, thank you, Suja. So what do we do with this kind of endometrial hyperplasia? The most important investigation for endometrial hyperplasia happens to be the histological examinations. Until and unless, see, you saw hyperplasia through what? Through TVS, right? Through ultrasound. It's not a naked eye examination. It's not through any history, and it's not through anything. It's through TVS. Patient had come to you with irregular menses, heavy menses, intermenstrual bleed, postpartum bleed, and out of the entire investigations, you went ahead and did TVS as well. I have taken your HMB classes, heavy menstrual bleeding, and in that I had specifically told you that most important for HMB, if you have to go and see, is the hysteroscopic guided biopsy. Never do a biopsy blind in patients perimenopausal age group with HMB, especially with HMB at any group. So you went ahead, did a TVS, there was an endometrial hyperplasia. Now you do not know whether it is simple or complex, so you went ahead and did a histological examination. That's your gold standard. Okay, diagnostic hysteroscopy should be considered because you want to be very discreet in taking out the biopsy. You're not taking out a biopsy from a thinned out endometrium which might not have endometrial atypia. It might just have endometrial hyperplasia. So you have to be very specific in taking biopsy. That is why we say hysteroscopic guided biopsy from that region where there was actually a crowding of endometrium, where you're finding this endometrium suspicious looking. Now, transvaginal ultrasound may have a role in diagnosing endometrial hyperplasia, but basically just the hyperplasia, nothing more than that. It just gives you a stimulus that, oh, this has to be investigated further. So you have to go ahead and do a direct visualization and then take a biopsy. As far as CT and MRI are concerned, they're very, very expensive tools. Unnecessarily, they're not going to help any which way further. Now, just imagine, have you ever got done a CT scan of a patient with endometrial hyperplasia? No. The answer is you go ahead and take a biopsy because it's not going to give you, it's not going to add anything to your otherwise very beautiful investigations of TVS. And obviously followed by a hysteroscopic biopsy. So the initial management, before you go any further, this line speaks volumes. Now listen to this. Women should be informed that the risk of endometrial hyperplasia without atypia progressing to endometrial cancer is less than 5% over 20 years. That's a huge, huge statement. Why it's a very important statement is because that's the level. That's the level of progression. So if there is a female who's, let's say, 68 years of age, she's coming to with postmenopausal bleeding, and there is endometrial hyperplasia, she's obese also. But if on hysteroscopic guided biopsy, it comes out to be endometrial hyperplasia without atypia, and all her relatives are like, oh my God, it's like, not only is she having postmenopausal bleeding, but there is a full-blown endometrial hyperplasia, we'll have to take out the, uterus. You can tell them this one sentence, that it's not a must for her to go through a big operation like hysterectomy till there is a need to do so. Why? Because there's only 5% chance that this endometrial hyperplasia without atypia will in fact progress to endometrial carcinoma in the coming 20 years. 20 years, not 5 years. 20 years. And that majority of the cases of endometrial hyperplasia without atypia usually regress spontaneously during the follow-up. So all we'll do will be a follow-up of this patient. Reversible risk factors such as obesity, use of HRT, they should be identified and they should be addressed if possible. So if she was on HRT, maybe you'd like to change the HRT. If she was on high dose estrogen, maybe you'll have to put it on low dose. Maybe you'll have to put her on progestogen. So you'll have to do those kind of adjustments to her. And otherwise, risk factors, if there are modifiable risk factors, maybe you should go ahead and think about it. That's what we are trying to say.